Ladies and gentlemen, please be seated.
Tonight, live from the Athens Shoulder Course Arena in Athens, Greece. This is the main event of the evening.
Get ready for the mini battles face to face, round 5. In the red corner, from Milan, Italy, the master of Anatomic, a full professor of orthopedics, Department of Biomedical Sciences, Humanitas University, residency program of orthopedics director at the Department of Biomedical Sciences in Humanitas University, head of the shoulder and elbow surgery unit, Humanitas Research Hospital, past president of the European Shoulder and Elbow Society, past president of the Italian Society Shoulder and Elbow Surgery, and member of the International Shoulder and Elbow Surgery Board. This is the one and only Alessandro, no mercy, Castagna. In the yellow corner, he flew all the way from the US, the master of reverse. He's professor of shoulder and elbow surgery at the Wayne H. Lewis, director of the Division of Shoulder and Elbow Surgery, Department of Orthopedic Surgery at Johns Hopkins University, Baltimore, USA. Ladies and gentlemen, this is the great Edward, the Executioner McFarland. Referee of this fight, born in Greece, working in the US, the Chief of Shoulder Surgery and Medical Director at the Institute of Joint Restoration and Research, Menlo Park, California. The Play No Games, John Ferocious Costouros. Tonight, we are going to witness the most anticipated match in the history of professional mini battling. Mini battles fans, are you ready? For the thousands in attendance, for the millions watching around the world, from the capital city of Greece, Athens, this is the last mini battle of the season. Let's get to rumble!
Okay, gentlemen, this is the final and most important mini battle. This will be for the undisputed heavyweight champion of the world. Okay? All right, let's begin. Okay, arthritis in the young patient, mini battle 5. So this is a 53-year-old male, right-hand dominant, who enjoys playing tennis for many years. Diagnosed with mild arthritis of the glenohumeral joint of his right shoulder, and he sustained a full-thickness rupture of the supraspinatus tendon in 2009. So at that time, he underwent arthroscopic treatment, arthroscopic rotator cuff repair. It also included debridement of some early arthrosis, labral debridement, microfracture, utilizing 2 knotless anchors. And he did well for several years until 2013, when he developed increasing pain and loss of motion, basically loss of about 10 degrees of flexion, external rotation, and internal rotation. So at that time, conservative treatment was undergone, including 3 PRP injections, and it bought some time, several years of clinical improvement. However, by 2017, some arthritis of the glenohumeral joint had developed. Okay, so at that time when he developed some increasing pain and development of arthritis, forward elevation of 160 degrees, external rotation with the elbow at the side of 40 degrees, external rotation with the arm in 90 degrees of abduction of 60 degrees, and internal rotation to L5 with palpable joint crepitus, pain in all planes, no night pain. Clinical signs, AC joint tenderness, which was mild, crepitus, as we indicated earlier, some pain with resistance in the scapular plane, positive near sign, positive speed sign, positive O'Brien sign, positive drop-off and apprehension signs. So here's a preoperative x-ray demonstrating post-surgical change from his prior arthroscopic rotator cuff repair. There's some cysts around the metallic anchor there in the greater tuberosity, an inferior osteophyte, which is quite prominent at the calcar. And let's go back to the CT scan here. This is the axial sequence. Here we go. Any thoughts from our two opponents here as far as glenoid morphology?
We agree. This is a static posterior subluxation with a B2, posterior erosion.
You know, I disagree with that.
Oh.
What do you think?
I just agree.
You disagree. Okay, we're looking at the coronal sequence here. Again, a very prominent osteophyte of the calcar, subchondral cyst formation in the glenoid. And now we're going to go to the oblique sagittal sequence. We didn't quite see the rotator cuff there, musculature. And here's the 3D reconstruction. Any additional thoughts so far?
Now it seems he has a good cuff, and this arthritis, especially with this B2, that is the big challenge. Yeah.
It's an easy case. The question is, though, how much is the retroversion? Did I see it up there, the mount?
Oh, you want to go back?
No, do we have a number?
Let's see here.
It looks more than 15 degrees.
It does. I don't see what the, can we go back to the prior slide, please? And no, it didn't really give us a number. So let's assume it's,
Yeah, more than 15, yeah.
yeah, I think it looks to be about 20 to 25 on just gross inspection. But so now we're going to go to the MRI, which is the next sequence here. So we're looking at axial sequence, scrolling down. Any thoughts about the subscapularis?
It's definitely not healthy.
But still there.
Yeah. There's the coronal fat suppressed sequence. The repair appears to be intact.
Good muscle trophicity.
Okay, so that's where we're at. So some preliminary thoughts, starting with the blue corner.
Sorry, he's going first.
Oh, the red?
Yeah. To me, it's not an easy case. It's very complicated, my friend. Very complicated. Young boy playing tennis with this posterior static subluxation that started years before. The plication fixing these things never works in my hands. And these are very often condemned to ending this up. So it is not easy because of the age. The age is making the difference, because otherwise the blue guy may be always right. But in some cases we are in doubt, and I am.
Okay, so you still adhere to the fact that it's a B2 glenoid with static posterior subluxation?
Yes, I do.
Okay. Is there a place in your experience, in your practice, for anatomic arthroplasty or not?
Well, I was fighting for a long time in my life for these cases, and I was failing with anatomic on the glenoid side. So then I was struck all of a sudden during the fight, and I opened my mind after a travel to France to some other options that are always anatomic, but a little different, forgetting about the glenoid part that is the weak link of this implant in this case. You want to see it?
Sure.
Now, yes, I show you after I was struck on my way on the road, like San Paulo, Can I see my short presentation, please? First of all, I must admit, I send my fellows or residents visiting other good surgeons, including Pascal Boileau. This is a very good one who stayed with Pascal 6 months and studying now. He's having a PhD with me. Go to the next, please, next. And we have this case with the results. And this is where I am now for this kind of condition. Next. This is the patient, similar age, very similar clinical condition of what you presented, Mr. Referee. Next. 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 So, active, pain, progressive range of motion, failed conservative treatment. So next, very similar to the case we are discussing. Which are the options in my hand? Arthroscopic, less invasive, but you don't know what you are achieving. Total shoulder. Symptoms relief, but short, mid-term results. Functional limitation, long-term durability, and complication are the issues. It will fail sooner or later, probably sooner rather than later. Reverse, back, please. You have a relief, clinical results with main function, little limitation, and a revision option in the future, but it is a good option in less active guys. But now, this is the last line. Hemiarthroplasty, that can be less invasive, convertibility, you may correct bone erosion, residual pain and complication may have. Go to the next now. So the option that I'm following now is this, pyrocarbon, French flag over there. This is a case from Pascal Boileau while my guy was visiting him. It is not him. I do the same now, but I have a short follow-up. Next. So these are the options. You know, the pyrocarbon has good elasticity, and it is very compatible, let's say, with the human body in this articular contact, mechanical contact. Next. So this the clinical result of Pascal case, pre-op, post-op, 6 months after, 12, 2 years, and 98 months after it. Very good. Next. This is the post-op over the glenoid, and you see that the glenoid is almost remodeling around it. Why? Next. This is the clinical result. Can you start the video? Again, this is Pascal, not me, and the presentation and the study that I will present with the results are done by my fellow resident, that is Riccardo Ranieri, and he was teaching me. So I send my young guys around the world so they bring back good experience and teach me something to improve. Next. So the inclusion criteria, this primary, watch B glenoid with a minimum follow-up. This is the study that they did. Fracture sequelae, osteonecrosis, inflammatory, ACD were exclusion criteria. Next. 45 shoulder, 41 with 3 CT scan. Next. I go quick. This is the distribution. Primary osteoarthritis 71%, instability 29%. Next. And this is the reaming done by Pascal, and you see that is correcting the posterior erosion and the inclination, the orientation anterior-posterior of the glenoid with this reamer. Next. And these are the conclusions. This asymmetrical anterior reaming allows to correct the glenoid retroversion at 6 degrees. Associated concentric reaming allows to correct posterior humeral subluxation, and the correction is maintained in a short to mid-term follow-up. Next, these are the results at 5 years of this group, 97% at 5 years, so quite satisfying. Next. Thank you for your attention, and my attitude now, not a complete anatomic, but I try to do this in this specific case. Run, reaming, and pyrocarbon hemiarthroplasty.
I have to say that is the most ridiculous thing I've ever heard of. It's basically a ream and run, and we all know that doesn't work. So the good thing about ream and run is it models the glenoid to put in a reverse. So, undressed here. So I have a little rebuttal to the professor's comments, and I think we will all at the end agree that a reverse is the way to go. So I should also recommend my co-authors of this thing. We've been sparring for the past couple weeks, and I have the perfect answer for his ridiculous thoughts. So can we go to the next slide, please? So my question to you first is, which of those two is me, and which is him? Who is the younger? I have more hair. So I think he's maybe the guy in the front. So next slide, please. So Dr. Castagna, you know, he's a very intelligent, wonderful man. He was born in Italy, went to the finest schools, and he practices in Milan, city of fashion, although he's not so fashionable at the moment. And he is a full professor, a master surgeon, and undeniably a famous guy worldwide. So next slide, please. That's in contrast to me, who I was born and raised in a shack in Kentucky. If you know Kentucky, it's where we make moonshine. And I went to public schools, had no money, went to a university, I can't remember the name. It's been called redneck more than once in my life, and also a professor. That's how we spell it in Kentucky, professor. And I personally think that this was advertised as a scapula thing. I'm glad it's not about the scapula because the scapula is too complicated and doesn't matter anyway. So next slide, please. So these are examples of the many publications by the professor. They're very encouraging to read these because most of them, I'm not sure what they mean. For example, effects of regenerative radioelectric asymmetry conveyor treatment on human normal and osteoarthritic chondrocytes exposed to IL-1B biochemical and morphologic analysis. I have no idea what that means, but I'm sure it is not relevant to this case.
Not at all.
Or also metal, this is another one I like, matrix metal proteases. Is that, did I say that right? How do you say that? And their inhibitors are altered in torn rotator cuff tendons, but also in the macroscopically and histologically intact portion of those tendons. What the hell does that mean? But to contrast, my publication, and next slide, please. Mine is more close to home. It's the only one that I've had get any play in the press, and it's about the toileting ability of patients after primary reverse total shoulder arthroplasty. And we know that this is a very important result for this patient. Next slide, please. So first off, why are we talking about arthroplasty in the first place? We need to know what this guy does for a living. Maybe he's actually, know what he said, maybe he's left-handed and they operated on the wrong side. So what other activities should he give up? And what level of tennis does he play? The guy did not look very fit. Like, if he plays tennis, it's club tennis. And is he willing to give it up if he has an operation? Next slide, please. So what I would say to this patient is, you know, he has to have realistic expectations or realistic goals. His surgery may not let him play back at the level that he did before, which probably is not very high. And any operation can fail, including pyrocarbon whatevers. And tennis is very rough on arthroplasty, so we know that anything that you do to the shoulder should last, hopefully, for a while before he gets another operation. So the treatment options really is what we all sort of go through. It's been discussed here all morning. There's the non-operative treatment options are debridement alone or more extensive debridement, partial cuff tear, cuff repair with graft, SCR. He actually didn't have a rotator cuff tear. It was surprisingly based on his examination. I would have thought that it was torn. Arthroplasty, of course, is hemiarthroplasty, Riemann run, which is basically the procedure the professor has told us about. You can do a resurfacing allograft, which only our host would do. And anybody was there earlier today. Anyway, so you could do a total shoulder with an inlay glenoid, pyrocarbon, as we mentioned, a total shoulder, reverse total shoulder. Next slide, please. So what I know about the shoulder is that the glenohumeral joint is tight, and it doesn't allow normal motion based primarily not only in the ligaments but the bony deformity. And the results are just not good around the glenoid when you do resurfacing. So why would I do a total? It's predictable pain relief. He did have a previous rotator cuff tear, which I think puts him at risk for failure of a total shoulder later. If he has no cuff tear, he will eventually get one, which means that he will someday need to get his reverse. And that way he gets only one operation. He doesn't have to get reoperated on 5 years from now or 10 years from now because this will last. The other thing, too, is the subscapularis, particularly if you're playing tennis, if you have a reverse, you don't have to worry about that. He also has significant contractures, so you need to make sure that his external rotation at 90 degrees is more than 60 degrees, or he won't be able to hit a tennis ball. He can go play golf. So one of the advantages of the reverse is you can do a release of the subscap actually, and they'll get more internal rotation so that they can get more of a swing, either over shoulder height or at lower level. And so I think that the advantages of a reverse way outweigh the use of pyrocarbon and voodoo. So let's see the next slide, please. So anyway, I think one thing you can do for a BT with the total shoulders, you can put the glenoid in a little retroversion. There's no data to accept that, although Mattson says that you can do that. Next slide, please. An augmented glenoid component that was not discussed, which is a good thing because they all fail. Next one. You can bone graft the glenoid. That too has a high failure rate. This study was from the group at Rothman, and they had a 30% failure rate with bone grafting. That's about the same that I get, but then I don't know what I'm doing. Next one. I am a very big fan of eccentric reaming. I think it doesn't damage or lose as much bone as people think it does, and it also lasts. So this is a study we had in JBJS, and we actually, I think it's my only publication. Next. So we had 40 patients, minimum 5-year follow-up. We did eccentric ream at 90% coverage, and there's only 1 or 2 failures in the group at 5 years, and we did have a pretty low rate of scapular notching, and almost everybody had significant improvement in their clinical parameters and problems. So I think in this patient, Professor, obviously a reverse arthroplasty is the way to go, and your treatment is going to make this patient miserable, and he is going to have more surgery in the future, whereas my procedure, my approach will be the best thing for this patient.
Well, I do believe that this is true if he's right-handed, but he's left-handed, and he can do very well with my treatment.
So some more information. So this patient, I met him when he was 40 years old. At that time, early osteoarthritis, a small tear on the rotator cuff. And so I get in, I do tenodesis of the biceps, repair of the calf, some microfracturing. Okay, the patient was perfect. 1 year, 2 years, 3 years, I was very happy. 4 years, 5 years, start having pain again and coming, and I say, okay, be patient, try a little bit more, reduce a bit your activity. I was afraid to do anything else. And then she comes at something like 51 and says to me, okay, doctor, we have to do something. So I said, okay, all my friends around the world, what would you do to this patient?
What did I say?
I don't remember really to say. I think reverse.
Different.
I think reverse.
Different. What's his glenoid?
Yeah. And half of the answers was anatomic, a little ream, accept some retroversion, do a bone block. The other half was reverse. So I said, no way to decide. So.
Oh, you have an answer. One thing, sucker punch. Oh!
So, Alex, are you reaming down to the neoglenoid when you're doing your correction for B2, all the way down?
Yeah. I need to make this regular. Again, I did a few cases of this. I started just 1 year ago after my fellow came back and told me it works. I did the study. So I cannot tell you the long-term results. So far, it is an option. The system is modular. So again, this may happen, honestly, to go for a revision sooner or later. But so far, the few cases, because these are not very common, luckily, and they are doing well, but it is a very short time.
And what are you doing to the posterior capsule in the setting of more advanced subluxation?
Yeah, well, you cannot change it. It is one of the issues why they have this posterior subluxation after the chronic, because the cause is there. The chronic posterior subluxation is creating a deformity that becomes permanent, plastic, not elastic. So I do not, somebody suggesting putting stitches or so, I'm not sure this will work. You know that there are philosophies about it. Ken Yamaguchi and help me, well, another one, and they are saying, why we want to change what nature made for a long time? And they are experimenting, creating a imperfect humeral component that is reproducing that anatomy and see what happens. Because you cannot correct the soft tissues when they are 50-something and they have this condition for many, many years. This is why, honestly, the option for the blue man can be also a good one.
Right.
Yeah, well, you know, the posterior capsule, I don't know, in reverses you release everything. The stability is really more dynamic one from the implants.
I mean, if one looks at the older literature of anatomics with B2 glenoids, there's Gilles Walsh and Pat Denard's study, high failure rates, especially with more advanced posterior subluxation. Tom Norris's earlier, older study with Hill, 50% failure. But then as the augments started to coming, some of the papers demonstrate good survivability and others don't. Ionati's work was favorable. You quoted some other work that was not favorable. What do you think that the augmented glenoids in the anatomic for B2 are going to have better longevity moving forward?
Well, it's hard to know, but it depends on what you call longevity, because those studies still are in the 5-year range. There may be a couple that I don't know of that are 10-year now. But the advantage of the ream and run is that you do it once and that's it. You don't have other operations. So I've not really done augments yet. Still waiting to see that they are going to survive. I think the literature is favorable so far.
Well, the augmented all poly, you mean?
Or both.
The all poly augmented, I don't trust that much because the poly is going to be worn. And my experience through the years were very bad when I was shocked by and I wasn't happy. So reverse is a good option. What I did that is a little different approach, expecting anyways a failure, just to buy time, is to use a modular system with a metal base plate that is ready for exchange after, let's say, 4, 5, 6 years. So I implant an anatomic. I warn my patient, listen, this will happen sooner or later. Come over to me at least once every 6 months in order to check if you have a posterior erosion or subluxation. And when I understand that the poly is now worn over the metal base, I make a conversion that is much different from a revision. And so this is a strategy I used a few times, and it did work, but it is just for buying time.
Great.
So if I heard you correctly, for a B2 glenoid where you're going to do reverse, you're not going to bone graft, you're not going to use an augmented base plate. So George earlier talked about his limits of version abnormality. What's your ideal range for base plate if you're going to adopt that method?
Well, I would say 25 degrees or 30. You know, they're all different, but you can really actually, the kind of implant that I use has a central screw that's, you know, once you, for those of you who've ever put a central screw in that catches the back cortex, those base plates aren't going anywhere. And there have been some instances where we could only get 2 screws in because it was so small, 3 screws. You know, I think there was, who was it that had on the market that had a base plate that had only 2 screws to begin with?
There are a few available, yeah.
Yeah, so they proved that you can get by with just 2 vertical screws and it will survive by and large as long as you have enough base plate covered. And I think that having 2 flat surfaces is better than having 2 oblique surfaces.
Yeah.
So
you've had good success having a base plate in 25 degrees of retroversion.
yeah, you can, it depends, you can generally ream enough, flat enough that you have good bone.
So it's more about fixation than version.
Absolutely.
In your hands.
And the other people suggest that there's a concern with medialization, but the trouble with those types of scapula is that you don't really know where they started, you know, and generally, even though you medialize a little bit, it makes it so that you can actually get the glenoid or get the humeral component in. You don't have to start taking more. You don't have to take more humeral bone. So I have a couple more slides. Can you put the slides back up? So anyway, so this is an interesting study that came out that they looked at patients who had reverse total shoulder. They had reverse total shoulder arthroplasties, and they did a literature systematic review, and they found that the golfers and swimmers, joggers, bicyclists, all pretty much got back to their previous level of sport, but only 50% of the tennis players. Next slide. And so their conclusion was that the majority of patients were able to return to their previous level of sport. Quote, however, the results are modest in overhead athletes, with a concerning number unable to return to tennis post-RSA. So this patient was sort of not a very good tennis player and probably was going to give up the sport anyway. Then a reverse would make good sense. But he's really very young. 49 is young. And if he really is an avid tennis player, like it suggests, then even I would probably do, a standard arthroplasty. And then the next slide, please. I do want to say, though, that I feel kind of beat up here, and so don't anybody have to cry for me or anything, but I was actually duped, you know. I wasn't told that this was the case, and it's an impossible topic, of course, and I didn't have time to train and was intimidated, and I didn't sleep last night, and I'm going against this famous guy, you know, and so I'm going to leave as soon as we're done here because I'm humiliated, so what can I say? But, you know, when you take on the top guys, you know, it's really, it's a tough arena is all I got to say.
Cassius Clay.
Yeah.
So by unanimous decision, you're conceding to the red corner.
Yes, and unfortunately, I have to say, yes, it's very painful, but I'll get bandages later.
Not painful, simply a good advice.
Is Mano still here? So what did you end up doing? You polled the world of colleagues. You got split information. What did you end up doing?
Well, you can see the next...
Okay. Let's go to the next slide then.
The answer.
Can we put up the mini battle presentation, please? So that's the answer.
Go on the slides and see the results.
Okay, let's go to the slides, please. It was a tough fight, but the blue corner appears to have won.
Next slide.
Is he still playing tennis?
Okay. Yes. And this is the CT scan after the operation. It's 2 years post-op. Yes.
Do we have a plain X-ray?
Yes.
Okay, great.
At least it's an Italian prosthesis.
Accepting some retroversion, putting some bone behind the glenoid base in the posterior part. This is the X-ray 7 years post-op.
Wow.
And this is the patient 7 years post-op. Yes. He has reduced activity due to my advice, but he's very active, and it's impossible to understand which is the shoulder that it was operated. Look at the external rotation.
Fabulous results.
And excellent. Most amazing, look at the internal rotation.
Wow.
Okay.
You know, I was thinking about doing that all along.
So we see the very interesting thing here is that there are some patients with external, reverse, that they have amazing rotations, internal and external. External.
Because the calf was...
Yes, probably yes.
Right.
So sometimes we'll talk about the worst results of reverse in terms of range of motion compared to anatomics. But I think it's the initial stage of the patient that we do a reverse or an anatomic that has to do a lot with these differences. This is what I'm thinking. Yeah.
And you told me that you made an interview of many surgeons before deciding, and you interviewed me. And what did I tell you about this?
I remember.
Use a Lima reverse, please.
No, any reverse.
Well, I changed my mind again.
Sure. So it looks like after a very rigorous 12-round bout, it's a draw. Congratulations.
Mr. Referee, thank you.
Thanks for letting me rep.
Thank you.